Hi, everybody. My name is Ashley Shustak. I'm a colon and rectal surgery fellow at Cleveland Clinic, Florida. I'm going to be presenting our research using the National Cancer Database, studying the impact of facility type on surgical outcomes in colon cancer patients. Dr. Wexner, our PI, has a number of disclosures, which you can see on the slide. None are related to our study. The incidence of colon and rectal cancer is increasing in our population. As we know, colorectal cancer is now the second most common cause of death in the United States, and there will be approximately 150,000 new diagnoses of colon cancer in 2024 in the U.S. Surgery is the gold standard treatment and only curative option for colon cancer. The U.S. healthcare system is highly variable, and as such, there are many types of treatment centers across the country. Patients are treated in different types of treatment facilities according to a number of factors, including their insurance coverage, area of residence, access to healthcare, and their own preference. To standardize cancer treatment across the United States, the Committee on Cancer, or COC, was created more than a century ago to give facilities accreditation of their cancer care. There are over 1,500 centers included in their registry today, and these facilities receive their cancer program category based on the number of cancer diagnoses per year and a number of other factors. These are the main four categories, though there are some small other groups as well who get special designations based on research funding. So as you can see, comprehensive community cancer programs were the highest number of patients in group for our patients with colon cancer. Our aim was to determine if surgical outcomes for patients with colon cancer differ based on the type of facility where they undergo surgery using the NCDB from 2010 to 2019. A retrospective analysis of patients with colon cancer was performed using the NCDB, which compiles information from the COC. The inclusion criteria included patients diagnosed with colonic adenocarcinoma, mucinous adenocarcinoma, and signet ring cell adenocarcinoma with clinical stage 1 through 3 cancers. Exclusion criteria included patients with unknown clinical stage 0, stage 4, neoadjuvant chemotherapy or radiation, no surgery, local excision as their primary surgery, and a missing facility type. Primary outcomes included overall survival, 30 and 90-day mortality, 30-day readmission, and conversion to open surgery. Secondary outcomes included surgical margins, examined and positive regional nodes, and length of inpatient hospital stay. A total of 125,935 patients diagnosed with colon cancer were included in our analysis. 50% of patients were female with a mean age of 68.9 years. Most tumors were located in the right colon, followed by left and then transverse. The majority of patients were diagnosed with adenocarcinoma, and most had stage 1 disease. Differences in demographic, clinical, and treatment characteristics can be seen in this table. The Charlson Comorbidity Score showed that academic research programs treated the healthiest patients with the lowest comorbidities, whereas integrated network cancer programs treated the most comorbid patients. Academic research programs treated more diverse patients with higher percentages of Black and Asian patients, while community cancer programs treated the highest percentage of white patients. Medicare was most commonly used in the community cancer programs, while Medicaid, private insurance, and uninsured was highest in academic research programs. Patients living in urban and rural areas were more likely to be treated at community cancer programs, whereas patients living in metro areas were most common to use academic research programs. The highest percentage of laparoscopic surgery was done at academic research programs, whereas the highest percentage of open surgery was at community cancer programs, and the highest percentage of robotic procedures was done at integrated network cancer programs. This figure shows trends in surgical approach at the different facility types for laparoscopic, open, and robotic surgery over the years. As you can see, in the top left, for academic research programs, there was an uptick of laparoscopic surgeries until a recent downtrend and uptick in robotic surgeries. Whereas the top right, community cancer programs have a shorter uptick in laparoscopic and robotic approaches. Not surprisingly, the percentage of open cases has gone down at all program types over the last few years. This table shows patient outcomes across the different facility types. Academic research programs had the highest percentage of negative surgical margins, though the percentages were fairly uniform throughout the facility types. The highest rate of conversion from laparoscopic to open surgery was in community cancer programs. 30-day mortality and 90-day mortality were the lowest at academic research programs, and overall survival was highest at academic research programs. Multivariate analysis for factors associated with overall survival demonstrated that, in comparison to academic research programs, treatment in all of the facilities was associated with a moderate increased risk for mortality. There was approximately an 8 to 9% increase in mortality in each of these other facilities. Though this is a small difference, and overall, we feel that patients are receiving good care despite their facility type. Surgical approach outcomes and survival differ among facility types. There's improved survival after colon cancer surgery at academic research programs. The reasons behind this may be enhanced research, clinical trials, and more strict adherence to evidence-based practice parameters at academic facilities. The NCDB revealed a trend to academic research programs performing more minimally invasive surgery and community hospitals with a slower rise. We know patients benefit from MIS approaches in colon surgery with less pain, earlier return of bowel function, shorter hospital stay, better overall survival, and faster recovery. Conversion rates differed among facility types, with academic research programs showing slightly lower rates. Conversion results in higher wound infection rates, postoperative issues, morbidity, and mortality. There are some limitations to our study. This is a very large database, so it's prone to type 1 errors. A large number of patients were excluded from our dataset due to missing facility type and clinical staging. And even though most of our outcomes were statistically significant, they may really not affect patients' overall outcome. In conclusion, better access to minimally invasive surgery and improved survival after colon surgery can be found at academic research programs. This can be used to guide resource allocation and target interventions at other facility types. Thank you so much, and I'd be happy to take any questions.